Welcome to our prolonged hyperglycemia lesson. The purpose of this video is to provide you with real-world nursing education that goes beyond just the nurse workbook alone. If you haven't seen our previous video all about our hypo and hyperglycemia, although it may seem basic, I highly recommend going back and watching it because this is the kind of information that's going to provide us with a strong foundation so we're able to feel comfortable when we move to more advanced concepts like we're going to in this lesson. We talked about in our prior lesson how prolonged hyperglycemia can be overall dangerous in so many ways. And we're gonna get into this now. But the truth about prolonged hyperglycemia is that it can happen without people even realizing that it's going on. So oftentimes when people have new onset diabetes, they're actually unaware that they're even diabetic to begin with, and they'll just start feeling overall bad. So when this happens, we normally see people come in for the very first time with something known as DKA. And this is going to be our diabetic ketoacidosis. So DKA is a lack of insulin, and this causes severe hyperglycemia. So this is when our body starts metabolizing its fat for energy, and the ketones that are released are acidic and begin to build up in the body. So ketones are produced as a byproduct of fat metabolism, and this creates a metabolic acidosis, and this makes our patients extremely ill. And if this is untreated long enough, this can be fatal. So typically, DKA is going to be caused by medication noncompliance. We can see this with infections or stress, and potentially this can be due to an underlying illness like a heart attack or stroke. And DKA can occur in either type 1 or type 2 of diabetes. And our other condition that could be confusing to a lot of people is known as our hyperglycemia hyperosmolar non-ketotic syndrome. This also could be abbreviated by HHNS or HNS. Well, this is severe hyperglycemia that's accompanied by extreme dehydration. So in this condition, there is some exogenous insulin, and this prevents ketones from forming. And this usually is a condition that has a slower onset. So in diabetes, this can occur the same as our diabetic ketoacidosis. And this could be from that medication noncompliance, the infection and stress, or something underlying. And in our non-diabetics, this can occur from pregnancy, pancreatitis, or it can even be drug-related. And this HHNS syndrome can be present normally in our type 2 diabetics. And this makes sense, right? Because type 2, think few. So if we do have some insulin going on that's stopping these ketones from forming, then we're really only going to see this in diabetes type 2. So we're going to compare and contrast these conditions since they're extremely similar, yet not at all. And both of these conditions are going to show the 3 Ps. This is going to be the polyphagia, polyuria, and polydipsia. We can also see weakness, tachycardia, hypotension, vision changes, nausea, vomiting, altered mental status, and so on. So our DK patient typically is going to have a blood glucose of 300 to 800, while our HHNS can be 600 to 1500. Now, of course, these are just kind of estimates. We could see sugar that is a lot higher in DKA. We could see some lower in this HHNS, but this is typically what we see. Also, we will see dehydration present in our DKA, and it will be severely present in our HHNS. This is one of the key factors that helps differentiate which condition this patient's in. Additionally, we'll see serum and urine ketones in our diabetic ketoacidosis, but in HHNS, we will not see any of this because remember, there's some insulin, so we don't have these ketones forming. We're gonna see an acidosis in our DKA, so diabetic ketoacidosis, where in our HHNS, we are not going to see it. And we're gonna see our elevated potassium and an elevated anion gap in our DKA, and we'll also see elevated potassium and sodium in our HHNS. What is an anion gap? Well, we are about to do a whole lesson on anion gap in the next lesson. And as far as our other things go, in DKA, we usually see our Kusumal respirations, which is the deep and fast to blow off CO2. And we'll also smell a fruity breath on our patients, and that's actually acetone. And in our HHNS, our key lab differences are going to be an increase in serum osmolality, and this is usually greater than 320. And for our diagnostics for both of these, we're going to make sure that we get some blood, our glucose, our electrolyte panels, our ABGs, urine ketones, and our osmolalities. And how do we treat both of these conditions? Well, even though we're about to talk about it a lot in our next lesson, we always want to make sure our first thing is our fluid replacement, because we talk so much about this dehydration being present. So we're going to start with a non-IV dextrose because, of course, we don't want sugar in our solutions. And we'll change to include dextrose whenever we get our blood sugar down. So remember that blood sugar is only one part of this equation when it comes to these conditions. We have a high blood sugar, but we also have this dehydration. And in DKA, we also have this acidosis going on. So fluid replacement is going to be number one, because we want those kidneys to be able to filter and do everything and be nice and hydrated to help correct everything else. Additionally, we do want to make sure we have our insulin. So we have that IV bolus so we can drop that blood sugar quickly, but we're going to follow this by an IV drip as well. And we can titrate this to scale. So anytime we give insulin, we're going to do this hourly goal to decrease our blood sugar by approximately 50 milligrams per deciliter per hour. So we don't want to drop them too fast, but we definitely want to get this down as quick as we possibly can. And we're going to also work on replacing our electrolytes, because these are going to be out of whack. So we want to make sure we keep our patients' NPO until their gap is closed and there's no ketosis and their blood glucose is under 200. And again, we're going to go much deeper into all three of these in our next lesson. And we want to always remember that only regular insulin can be given through an IV. So when we're transitioning to a sub-Q basal insulin, we're going to continue our IV insulin for 1 to 2 hours to prevent any reoccurring hyperglycemia. Why is this, or what exactly does this mean? Because this is something that can be very lost in our education when it comes to treating our DK patients. So our regular insulin is going to have that rapid onset, and it's going to have its peak as well. So this is something we can measure through an IV. But our basal insulin is actually acting as our pancreas, and it's long-acting insulin. It's providing a steady stream of insulin in the body. So this makes it really hard to measure if we were to give this IV. So if we think about this and we give our basal insulin IM, then we'll have this slow onset of this steady trickle of insulin coming in, and then we'll keep our patient on the regular insulin drip for 1 to 2 hours, because this allows us to keep controlling or rapidly keeping that insulin there to keep the blood sugar down until the basal insulin picks up, and then we're able to shut them off the regular insulin drip. This concludes our prolonged hyperglycemia lesson. I'll see you in the next one.